Kita lanjut baca untuk GINA 2024, episode 3, Risk Factors for Development of Persistent Airflow Limitation. The average rate of decline in FEV1 in non-smoking healthy adults is 15 until 20 milliliter per year. People with asthma may have an accelerated decline in lung function and develop airflow limitation that is not fully reversible. This is often associated with more persistent dyspnea. Independent risk factors that have been identified for persistent airflow limitation include exposure to cigarette smoke or noxious agents, chronic mucus hypersecretion, and asthma exacerbations in patients not taking ICS. Children with persistent asthma may have reduced growth in lung function, and some are at risk of accelerated decline in lung function in early adult life. There is no clear evidence that treatment with ACS prevents accelerated decline in post-bronchodilator lung function, that it prevents development of persistent airflow limitation. Risk factors for medication side effects. Choices with any medications are based on the balance of benefit and risk. Most people using asthma medication do not experience any side effects. The risk of side effects increases with higher doses of medications, but these are needed in few patients. Systemic side effects that may be seen with long-term high-dose ICS include easy bruising and increase beyond the usual age-related risk of osteoporosis and fragility fractures, cataracts, glaucoma, and adrenal suppression. Local side effects of ICS include oral candidiasis or thrush and dysphonia. Patients are at greater risk of ICS side effects with higher doses or more potent formulation, and for local side effects with incorrect inhaler technique. A glossary of asthma medication has been added as an appendix at the end of this report. Drug interaction with asthma medications, concomitant treatment with cytochrome P450 inhibitors such as ketoconazole, ritonavir, itraconazole, and erythromycin or clarithromycin may increase the risk of ICS adverse effects such as adrenal suppression, and with short-term use may increase the risk of cardiovascular adverse effects of the LABA, salmeterol, and vilanterol alone or in combination with ICS. Concomitant use of this medication is not recommended. Role of lung function in assessing asthma control. Does lung function relate to other asthma control measures? Lung function does not correlate strongly with asthma symptoms in adults or children. In some asthma control tools, lung function is numerically average or added with symptoms, but this is not recommended because if the tools include several symptom items, this can outweigh clinically important differences in lung function. In addition, low FEV1 is a strong independent predictor of risk of exacerbation even after adjustment for symptom frequency. Lung function should be assessed at diagnosis or start of treatment after 3 until 6 months of ICS-containing treatment to assess the patient's personal base FEV1 and periodically thereafter. For example, in most adult patients, lung function should be recorded at least every 1 until 2 years, but more frequently in higher risk patients, including those with exacerbation and those at risk of decline in lung function. Lung function should also be recorded more frequently in children based on asthma severity and clinical course. Once the diagnosis of asthma has been confirmed, it is not generally necessary to ask patients to withhold their irregular or as-needed medication before visits, but preferably the same condition should apply at each visit. How to interpret lung function test results in asthma. Although FEV1% predicted identifies patients at risk of asthma exacerbations independent of symptom level, especially if FEV1 is less than 60% predicted, is a risk factor for lung function decline independent of symptom levels. If symptoms are few, such as limitation of lifestyle or poor perception of airflow limitation, which may be due to untreated airway inflammation. Normal FEV1. A normal or near normal FEV1 in a patient with frequent respiratory symptoms, especially when symptomatic, prompts consideration of alternative causes for the symptoms. Persistent bronchodilator responsiveness. Finding significant bronchodilator responsiveness, increase in FEV1 more than 12% and more than 200 milliliter from baseline in a patient taking ICS-containing treatment or who has taken a SABA within 4 hours or a LABA within 12 hours or 24 hours for a once daily LABA suggests uncontrolled asthma, particularly for adherence and or incorrect technique. In children, spirometry cannot be reliably obtained until age 5 years or more, and it is less useful than in adults. Many children with uncontrolled asthma have normal lung function between flare-ups. How to interpret changes in lung function in clinical practice. With regular ICS treatment, FEV1 starts to improve within days and reach a plateau after around 2 months. The patient's highest FEV1 reading personal best should be documented as this provides a more useful comparison for clinical practice than FEV1% predicted. If predicted values are used in children, measure their height at each visit. Some patients may have a faster than average decrease in lung function and develop persistent incompletely reversible airflow limitation. While a short-term 3 month trial of higher dose ICS or ICS LABA may be appropriate to see if FEV1 can be improved, high doses should not be continued longer than this if there is no response. The between visit variability of FEV1 up to 12% week to week or 50% years to years in healthy individuals limits its use in adjusting asthma treatment or identifying accelerated decline in clinical practice. The minimal important difference for improvement and worsening in FEV1 based on patient perception of change has been reported to be about 10%. The role of short-term and long-term lung function monitoring. Once the diagnosis of asthma is made, short-term peak expiratory flow monitoring may be used to assess response to treatment, to evaluate triggers, including at work, for worsening symptoms, or to establish a baseline for action plans. After starting ICS, personal-based PEF from twice daily readings is reached on average within 2 weeks. Average PEF continues to increase and diurnal PEF variability to decrease for about 3 months. Excessive variation in PEF suggests optimal asthma control and increases the risk of exacerbation. Long-term PEF monitoring is now generally only recommended for patients with severe asthma or those with impaired perception of airflow limitation. For clinical practice, displaying PEF result on a standardized chart may improve accuracy of interpretation. Home spirometric monitoring has been used in some clinical trials. Careful training of patients in spirometric technique is essential. Results from clinic-based and home-recorded spirometry are not interchangeable. Assessing asthma severity. The current concept of asthma severity is based on difficulty to treat. The current concept of asthma severity recommended by an ATS or EES task force and included in most asthma guidelines is that asthma severity should be assessed retrospectively from how difficult the patient's asthma is to treat. This is reflected by the level of treatment required to control the patient's symptom and exacerbation. After at least several months of treatment, this definition is mainly relevant to and useful for severe asthma. By this definition, severe asthma is defined as asthma that remains uncontrolled despite optimized treatment with high-dose ICS LABA or that requires high-dose ICS LABA to prevent it from becoming uncontrolled. Severe asthma must be distinguished from asthma that is difficult to treat due to inadequate or inappropriate treatment or persistent problems with adherence or comorbidities such as chronic rhinosinusitis or obesity. They need very different treatment compared if asthma is relatively refractory to high-dose ICS LABA or even oral corticosteroids. Moderate asthma is asthma that is well controlled with step 3 or step 4 treatment with low or medium dose ICS LABA in either treatment track. Mild asthma is asthma that is well controlled with low intensity treatment as neither low dose ICS formoterol or low dose ICS plus as needed ABA. The utility of this retrospective definition of asthma severity is limited by the fact that it cannot be assessed unless good asthma control has been achieved and treatment step down to find the patient's minimum effective dose at which their asthma remains well controlled, or unless asthma remains uncontrolled despite at least several months of optimized maximal therapy. The terms severe asthma and mild asthma are often used with different meanings than this. In the community and in primary care, the terms severe or mild asthma are more commonly based on the frequency or severity of symptoms of exacerbation, irrespective of treatment. For example, asthma is commonly called severe if patients have frequent or troublesome asthma symptoms regardless of their treatment, and mild asthma is commonly used if patients do not have any symptom or if symptoms are quickly relieved. In epidemiological studies and clinical trial, asthma is often classified as mild, moderate, or severe based only on the prescribed treatment by GINA or BTS step, regardless of patient's level of asthma control. This assumes that the prescribed treatment was appropriate for the patient's needs, but asthma is often undertreated or overtreated. Most Clinical trials of biologic therapy enroll patients with asthma that is uncontrolled despite taking medium or high dose ACS LABA, but contributory factors such as incorrect inhale technique, poor adherence, and comorbidities are rarely assessed and treated before the patient's eligibility for enrollment is considered. Some clinical trial participants may therefore have difficult to treat rather than severe asthma. Some guidelines also retain another older classification of asthma severity based on symptom and sub-frequency, night waking, lung function, and exacerbation before ICS-containing treatment is started. This classification also distinguishes between intermittent and mild persistent asthma, but this historically distinction was arbitrary. It was not evidence-based, but was based on an untested assumption that patients with symptoms less than equal to 2 days per week were not at risk and would not benefit from ICS, so should be treated with SABA alone. However, it is not now known that the patient with so-called intermittent asthma can have severe or fatal exacerbation, and that their risk is substantially reduced by ICS-containing treatment compared with SABA alone. Although the symptom-based classification is stated to apply to patients not on ICS-containing treatment, it is often used for patients taking this medication. This can cause confusion, as a patient's asthma may be classified differently. They may be prescribed different treatment depending on which definition the clinician or healthcare system uses. For low-resource countries without access to effective medication such as ICS, the World Health Organization definition severe asthma includes a category of untreated severe asthma. This category corresponds to uncontrolled asthma in patients not taking any ICS-containing treatment. The patient's view of asthma severity. Patients may perceive their asthma as severe if they have intense or frequent symptoms, but this does not necessarily indicate underlying severe disease. The symptom and lung function can rapidly become well controlled with commencement of ICS-containing treatment or improve inhaler technique or adherence. Likewise, patients often perceive their asthma as mild if they have symptoms that are easily relieved by SABA or that are infrequent. Of concerns, patients often interpret the term mild asthma to mean that they are not at risk of severe exacerbation and do not need to take ICS-containing treatment. This is often described as patients underestimating their asthma severity, but instead it reflects their different interpretation of the word severity and mild compared with the academic usage of these terms. How useful is the current retrospective definition of asthma severity? The retrospective definition of severe asthma based on difficulty to treat has been widely accepted in guidelines and in specialist clinical practice. It has obvious clinical utility as it identifies patients who, because of their burden of disease and incomplete response to optimized conventional ICS-based treatment, may benefit from referral to a respiratory physician for further investigation, phenotyping, and consideration of additional treatment such as biologic therapy. It is appropriate to classify asthma as difficult to treat rather than severe if there are modifiable factors such as incorrect inhaler technique, poor adherence, or untreated comorbidities, because asthma may become well controlled when such issues are addressed. By contrast, the clinical utility of the retrospective definition of mild asthma is much less clear. There is substantial variation in opinions about the specific criteria that should be used. For example, whether IPV1 should be more than equal to 80% predicted in order for asthma to be considered mild, and whether the occurrence of any exacerbation precludes a patient's asthma being classified as mild for the next 12 months. There are too few studies of the underlying pathology to discern whether isolated exacerbation necessarily implied greater inherent severity, especially given the contribution of external triggers such as viral infection or allergen exposure to sporadic exacerbation. Further, by this definition, asthma can be classified as mild only after several months of ICS-containing treatment, and only if asthma is well controlled and low dose ICS or as needed low dose ICS formoterol, so this definition clearly cannot be applied to patients with uncontrolled or partly controlled symptoms who are taking SABA. Finally, retrospective classification of asthma as mild appears of little value in deciding on future treatment. In addition, in the studies of as needed ICS formoterol, baseline patient characteristics such as daily delivery user, lower lung function or history of exacerbation, or even baseline blood eosinophils or FeNO, did not identify patients who should instead be treated with daily ICS. Instead, decision about ongoing treatment should be based upon the large evidence base about the efficacy and effectiveness of as-needed ICS formoterol or daily ICS, together with an individualized assessment of the patient's symptom control, exacerbation risk, predictors of response, and patient's preference. However, the most urgent problem with the term asthma, regardless of how it is defined, is that it encourages complacency, since both patients and clinicians often interpret mild asthma to mean that the patient is at low risk and does not need ICS-containing treatment. However, up to 30% of asthma exacerbation and death occur in people with infrequent symptoms, for example, less than weekly or only on strenuous exercise. Interim advice about asthma severity descriptors for clinical practice. GINA continues to support the current definition of severe asthma as asthma that remains uncontrolled despite optimized treatment with high-dose ICS LABA or that requires high-dose ICS LABA or biologic therapy to prevent it from becoming uncontrolled. GINA also maintains the clinically important distinction between difficult to treat and severe asthma. For patients who have had a good asthma response to biologic therapy, it may be helpful for administrative reasons to describe their asthma as example grade here. Severe eosinophilic asthma while controlled on therapy to indicate that biology therapy is needed to maintain their improved status. For discussion about the concept asthma, remission on treatment, see page 50. We suggest that in clinical practice, the term asthma should generally be avoided if possible because of the common but mistaken assumption by patients and clinicians that it equates to low risk and that ICS treatment is not needed. Instead, assess each patient's symptom control and risk factors on their current treatment, as well as multimorbidity and patient goals and preference. Explain that patients with infrequent or mild asthma symptoms can still have severe or fatal exacerbation if treated with SABA alone, and that this risk is reduced by half to two-thirds with low-dose ICS or with as-needed low-dose ICS for material. Ensure that you prescribe ICS-containing therapy to reduce the patient risk of severe exacerbation and treat any modifiable risk factors of core or comorbidities using pharmacologic or non-pharmacologic strategies. Mild asthma is a retrospective label, so it cannot be used to decide which treatment patients should receive. Advice has been provided in section 4 about which patients are suitable for low-intensity treatment. For health professional education, the term apparently mild asthma may be useful to highlight the discordance between symptoms and risks that patients with infrequent or mild symptoms who might therefore appear to have mild asthma can still have severe or fatal exacerbation. However, apparently mild asthma in English can easily be mistranslated into some languages as obviously mild asthma, which is the opposite of the intended meaning. Alternative phrases include asthma that seems to be mild. Regardless of the term used, explain that asthma control tools such as AZQ and ACT assess only one domain of asthma control and only over a short period of time, and that patients with infrequent interval symptoms are overrepresented in studies of severe, near fatal, and fatal asthma exacerbation. Always emphasize the need for and benefit from ICS-containing treatment in patients with asthma, regardless of their symptom frequency or severity, and even if they have no obvious additional risk factors. For epidemiologic studies, if clinical details are not available, describe the prescribed or dispensed treatment without imputing severity. Patient prescribed SABA with no ICS rather than mild asthma, since treatment options change over time and may differ between guidelines, state the actual treatment class rather than a treatment step. For a clinical trial, describe the patient's population by the level of asthma control and treatment. For example, patient with uncontrolled asthma despite medium dose ICS LABA plus as needed SABA rather than moderate asthma. Further discussion is clearly needed, given the importance of mild asthma and the discordance between its current academic definition and the various ways that the term is used in clinical practice. GINA is continuing to discuss these issues with a wide range of stakeholders. The aim is to obtain agreement among patients, health professionals, researchers, industry, and regulators about the implications for clinical practice and clinical research of current knowledge about asthma, pathophysiology and treatment, and whether or how the term mild asthma should be used in the future. Pending the outcomes of this discussion, no change has been made to use of the term mild asthma elsewhere in these GINA strategy reports. How to distinguish between uncontrolled asthma and severe asthma. Although good symptom control and minimal exacerbation can usually be achieved with ICS containing treatment, some patients will not achieve one or both of these goals, even with a long period of high-dose therapy. In some patients, this is due to truly refractory severe asthma, but in many others, it is due to incorrect inhaler technique, poor adherence, overuse of SABA, comorbidities, persistent environmental exposure, or psychosocial factors. It is important to distinguish between severe asthma and uncontrolled asthma because lack of asthma control is a much more common reason for persistent symptoms and exacerbation and can be more easily improved. The most common problems that need to be excluded before making a diagnosis of severe asthma are poor inhaler technique, poor medication adherence, incorrect diagnosis of asthma with symptoms due to alternative conditions such as inducible laryngeal obstruction, cardiac failure, or lack of illness, multimorbidities such as rhinosinusitis, GERD, obesity, and obstructive sleep apnea, ongoing exposure to sensitizing or irritant agents in the home or work environment, including tobacco smoke. Investigating persistent control and exacerbation despite treatment. Watch patient using their inhaler, discuss adherence and barriers to use. Watch patient use their inhaler, check again inhaler checklist, show correct method, and recheck up to 3 times. Recheck each visit. Have emphatic discussion to identify poor adherence with maintenance treatment. For example, many patients don't use their inhaler as prescribed in the last 4 weeks. How many days a week have you taken it? Or do you find it easier to remember your inhaler in the morning or in the evening? Ask about beliefs, cost of medication, and refill frequency. Confirm the diagnosis of asthma. If no evidence of variable airflow limitation on spirometry or other testing, consider halving ICS dose and repeating lung function after 2 until 3 weeks. Check patient has action plan. Consider referring for challenge tests. If possible, remove potential risk factors. Assess and manage comorbidities for adults, adolescents. Switch to GINA track 1 if available to reduce exacerbation and simplify regimen. Check for risk factors or inducers such as smoking, beta blockers or NSAID, or occupational or domestic allergen exposure and address as possible. Check for and manage comorbidities, for example, rhinitis, obesity, GERD, obstructive sleep apnea, depression, or anxiety that may be contributing to symptoms or exacerbation. Consider treatment step up. Consider short term, 3 until 6 months. Step up to next treatment level or alternative option. On present level, use shared decision making and balance potential benefits and risks. Refer for expert advice. If asthma is still uncontrolled after 3 until 6 months on high dose ICS LABA or with ongoing risk factors, refer to expert advice. Refer earlier than 6 months if asthma very severe or difficult to manage, or if doubts about diagnosis or if occupational asthma is suspected. Principles of asthma management in adults, adolescents, and children 6 until 11 years. Key points: the patient health professional partnership. Effective asthma management requires partnership between the person with asthma or the parent or caregiver and their healthcare providers. Teaching communication skills to healthcare provider may lead to increased patient satisfaction, better health outcomes, and reduced use of healthcare resources. The patient's ability to obtain, process, and understand basic health information to make appropriate health decisions should be considered. Goals of asthma management. The GINA goal of asthma management is to achieve the best possible long-term outcomes for the individual patient. This may include good long-term symptom control, few or no asthma symptom, no sleep disturbance due to asthma, and unimpaired physical activity, and minimize long-term risk of asthma-related mortality exacerbation, persistent airflow limitation, and side effect of treatment. The patient's own goals should also be identified. Remission of asthma can be identified in children and in adults, either clinical remissions or complete remission, and either off treatment or on treatment. Definition and criteria vary. The concept of clinical remission on treatment is consistent with the long-term goal of asthma management promoted by GINA to achieve the best possible long-term asthma outcomes for each patient. Research among patients who have or have not experienced clinical or complete remission of asthma, either off treatment or on treatment, provides important opportunities for understanding underlying mechanism of asthma to develop new approach to asthma prevention and management. This will be facilitated by using standardized criteria and assessment tools. Take care of using the term remissions in conversations with patient or parent or caregiver, as they may assume it means a cure or may associate it with cancer or leukemia. Explain what you mean and that is asthma symptoms have gone quiet for a while, they may recur. Making decision about asthma treatment. Asthma treatment is adjusted in a continuous cycle of assessment, treatment, and review of the patient response in both symptom control and future risk of exacerbation and side effects, and of patient's preference. For population level decision about asthma medication, like national guidelines, ensure health but symptom for population level decision. A health maintenance organization or national formularies that the preferred regimen in step 1 until 4 represent the best treatments for most patients based on evidence from randomized controlled trials, meta-analysis, and observational studies about safety, efficacy, and effectiveness with a particular emphasis on symptom burden and exacerbation risk. For step 1 to 5, there are different preferred population level recommendations for different age groups. Adults or adolescent, children 6 until 11 years, children 5 years and younger. In step 5, there are also different preferred population level recommendation depending on the inflammatory phenotype, type 2 or non-type 2. For individual patients, shared decision making about treatment should also consider any patient characteristic or phenotype or environmental exposure that predict the patient's risk of exacerbation or other adverse outcomes or their likely response to treatment, together with the patient's goals or concern and practical use issues, and technique, adherence, medication access, and cost to the patient. Optimize asthma management, including inhaled therapy and non-pharmacologic strategies to reduce the need for oral corticosteroid and their multiple associated adverse effects. The patient healthcare provider partnership. Effective asthma management requires the development of a partnership between the person with asthma or the parent or caregiver and healthcare providers. This should enable the person with asthma to gain the knowledge, confidence, and skills to assume a major role in the management of their asthma. Self-management education reduces asthma morbidity in both adults and children. There is emerging evidence that shared decision making is associated with improved outcomes. Patient and caregivers should be encouraged or to participate in decision about treatment and given the opportunity to express their expectation and concern. This partnership needs to be individualized for each patient. A person's willingness and ability to engage in self-management may vary depending on factors such as ethnicity, literacy, understanding of health concept or health literacy, numeracy, beliefs about asthma and medication, desire for autonomy, and the healthcare system. Good communication by healthcare provider is essential as the basis for good outcomes. Teaching healthcare provider to improve their communication skills can result in increased patient satisfaction, better health outcome, and reduce without lengthening consultation times. It can also enhance patient adherence. Training patients to give information clearly, seek information, and check their understanding of information provided is also associated with improved adherence with treatment recommendation. Key strategies to facilitate good communication: a congenital demeanor, friendliness, humor, and attentiveness, allowing the patient to express their goals, beliefs, and concerns, empathy, reassurance, and prompt handling of any concern, giving encouragement and praise, giving appropriate personalized information, providing feedback and review, how to reduce the impact of low health literacy, other information from must to least important, speak slowly and use simple words, avoid medical language if possible, simplify numeric concept, use number instead of percentage, frame instructions effectively, use illustrative anecdotes, drawings, pictures, table, or graph, confirm understanding by using the teach back method, use patient to repeat instruction as a second person, like nurse, family member, to repeat the main message, pay attention to non-verbal communication by the patient, make patients feel comfortable about asking questions. Health literacy and asthma. There is increasing recognition of the impact of low health literacy on health outcomes, including in asthma. Health literacy means much more than the ability to read. It is defined as the degree of which individuals have the capacity to obtain, process, and understand basic health information and service to make appropriate health decisions. Low health literacy is associated with reduced knowledge and worse asthma control. In one study, low numeracy among parents of children with asthma was associated with higher risk of exacerbation. Intervention adapted for cultural and ethnicity perspective have been associated with improved knowledge and significant improvement in inhalant technique. Suggested communication strategies for reducing the impact of low health literacy are shown in box 3. Long-term goal of asthma management. The long-term goal of asthma management from a clinical perspective is to achieve the best possible outcomes for the patient, including long-term symptom control and long-term asthma risk minimization. This includes preventing exacerbations, accelerated decline in lung function, and medication adverse effects. At the population level, the goals of asthma management also include minimizing asthma death, urgent healthcare utilization, and the socioeconomic impacts of uncontrolled asthma. It is also important to elicit the patient's or parent or caregiver goals regarding their asthma, as this may differ from medical goals. Shared goals for asthma management can be achieved in various ways with consideration of differing healthcare system, medication availability, and cultural and personal preference. Long-term goal of asthma management. The goal of asthma management is to achieve the best possible long-term asthma outcomes for the patient. Long-term asthma symptom control, which may include few or no asthma symptoms, no sleep disturbance due to asthma, unimpaired physical activity, long-term asthma risk minimization, which may include no exacerbation, improve or stable personal-based lung function, no requirement for maintenance systemic corticosteroid, no medication side effects. The patient's goal for their asthma may be different from these medical goals as the patient and what they want from their asthma treatment. When discussing the best possible asthma outcomes with a patient, consider their goals, their asthma phenotype, clinical features, multimorbidity, risk factors, including severity of airflow limitation, practical issues, including the availability and cost of medication, and the potential adverse effect of treatment. Assessing symptom control is not enough. The patient's risk factor, including history of exacerbation, should always also be assessed. Symptom control and risk may be discordant. Patients with few or no symptoms can still have severe or fatal exacerbation, including from external triggers such as viral infection, allergen exposure, if sensitized, or pollution. Remission of asthma. Remission of asthma has been investigated extensively in the past, most commonly remission of childhood asthma off treatment. Definitions and criteria vary, but they commonly refer to either clinical remission, no asthma symptom or exacerbation for a specific period, or complete or pathophysiological remission, also including normal lung function, airway responsiveness, and or inflammatory markers. There has been interest in remission of treatment and remission on treatment. For example, with biologic therapy for severe asthma, the concept of clinical remission on treatment is consistent with the long-term goal of asthma management promoted by GINA, which is to achieve the best possible long-term asthma outcomes for the patient. When discussing the best possible outcomes with a patient, consider their own asthma goals, their asthma phenotype, clinical features, multimorbidity, risk factors, including severity of airflow limitation, practical issues including the availability and cost of medication, and the potential adverse effects of treatment. Research in patients who have or have not experienced clinical or complete remission of asthma, either off treatment or on treatment, provides important opportunities for understanding the heterogeneous and interconnected underlying mechanism of asthma and for developing new approach to asthma prevention and management. This will be facilitated by using standardized criteria and tools. Remission of childhood asthma. Reported rates of remission of treatment from studies in children with wheezing or asthma vary depending on the population, definition, and length of follow-up. For example, in one study, 59% of wheezing preschool children had no wheezing at 6 years, whereas in another study, only 15% of children with persistent wheezing at or after 9 years had no wheezing at 26 years. Clinical remission is more frequent than pathophysiological remission at all age. The most important predictors of asthma remission in school age children are fewer, milder, or decreasing frequency of symptomatic episodes, good or improving lung function, and less airway responsiveness. Risk factors for persistent of childhood asthma include atopy, parental asthma or allergy, later onset of symptom, wheezing without pulse, and maternal smoking or tobacco smoke exposure. Remission is not cure. After remission in childhood or adolescent, asthma often recurs later in life. Children whose asthma has remitted have an increased risk of accelerated lung decline in adulthood, independent form, but synergistic with tobacco smoking, and they may develop persistent airflow limitation, although this is less likely than for those whose asthma has persisted. This suggests the importance of monitoring lung function in people with remission of asthma symptoms. To date, there is no evidence that intervention in childhood increases the likelihood of remission of asthma or reduces the risk of recurrence. However, treatment of asthma in childhood with inhaled corticosteroids substantially reduces the burden of asthma on the child and family. reduce absence from school and social events, reduce the risk of exacerbation and hospitalizations, and allows the child to participate in normal physical activity. Parents or caregivers often ask if the children will grow out of their asthma and will not need treatment in the future. Current consensus support the following advice for discussion like this. If the child has no reported symptoms, check for evidence of ongoing disease activity and check lung function if testing is available. Use a description like asthma has gone quiet for the present to help avoid misunderstanding. If you use the term remission with parents or caregivers, explain the medical meaning because it is often interpreted as meaning a permanent cure. Advise parents or caregivers that even if the child's symptoms resolve completely, their asthma may recur later. Emphasize the benefits of taking controlled treatment for the child's current health, their risk of asthma attacks, and their ability to participate in school and sporting activities while avoid claims about effect of therapy on future asthma outcomes. Research needs clinical questions about remission of treatment in children focus on the risk factors for asthma persistent and recurrence, including clinical, pathological, and genetic factors, the effect of risk reduction strategies on the likelihood of remission, whether monitoring after remission to allow early identification of asthma recurrence improves outcomes, and whether progression to persistent and full limitation can be prevented. Clinical questions about remission on treatment in children with severe asthma treated with biologic therapy include investigating whether inhaled anti-inflammatory therapy can be down titrated. Remission of adult asthma. Clinical or complete remission of treatment has been observed in some adults, either spontaneously or after cessation of controlled treatment. For example, 15.9% of patients with adult onset asthma experience clinical remission, no asthma symptoms, and no asthma medication within 5 years. Remission is sometimes seen in people with occupational asthma after cessation of exposure. Clinical remission of asthma in adult life is more common with childhood onset asthma than adult onset asthma. However, persistence of airway hyperresponsiveness and or airway inflammation is found in most adults with clinical remission of asthma. In recent years, there has been increasing interest in asthma remission on treatment, particularly with biologic therapy for severe asthma. Various definitions have been proposed. For clinical remission, these often include criteria such as no asthma symptoms, no exacerbation, no use of LCS, and stable or improving lung function over a defined prolonged period. For complete remission, normalization or of airway responsiveness and or inflammatory markers have been proposed. For patients with severe asthma treated with biological therapy and medium or high dose ICS in combination with a long acting beta 2 agonist, remission rates will vary depending on the baseline characteristic of the population studied and the criteria for and duration of remission, including how no symptoms is assessed. Baseline predictors of remission on treatment with various biologic therapy for severe asthma include better short-term asthma symptom control scores, better lung function, fewer comorbidities, earlier asthma onset, and no or lower maintenance OCS use at baseline. In a study of clinical remission of treatment of adult onset asthma, the only baseline predictors of clinical persistence were moderate to severe airway hyperresponsiveness and nasal polyps. Although clinical asthma remission on treatment has been most extensively investigated in adults with severe asthma treated with biologic, the concept is relevant to patients with asthma of any severity and any treatment, including ICS-containing therapy, oral pharmacotherapy, allergen immunotherapy, and non-pharmacological interventions. In the lay media, the word remission is most often heard in association with cancer or leukemia. So if it is used in discussion with patient, the medical meaning for asthma should be explained. If the patient experiences clinical remission, explain that this does not mean permanent cure and that they should not stop taking any of their asthma medication except on medical advice. Research needs for asthma remission on treatment in adults include the association between clinical criteria with biomarker, imaging, or pathology sample, including for omics analysis that may reflect the underlying disease process, and investigation of predictors of long-term remission or recurrence. The framework for validating proposed criteria for remission on treatment will depend on their intended purpose. For example, as an assessment tool in clinical practice for prognosis of continued long-term stability or for identifying new targets for therapy. Clinical and qualitative research with a range of treatment is needed to know whether aiming for remission will improve long-term outcomes for patients with asthma. Personalized control-based asthma management. Asthma control has two domains: symptom control and risk reduction. In control-based asthma management, pharmacological and non-pharmacological treatment is suggested in a continual cycle that involves assessment of symptom control and risk factors. Treatment and review by appropriately trained personnel to achieve the goals of asthma treatment. Asthma outcomes have been shown to improve after the introduction of control-based guidelines or practical tools for implementation of control-based management strategies. The concept of control-based management is also supported by the design most randomized controlled medication trials in which patients are identified for a change in asthma treatment based on features of poor symptom control with or without other risk factors such as low lung function or a history of exacerbation. Since 2014, GINA asthma management has focused not only on asthma symptom control but also on personalized management of the patient's modifiable risk factors for exacerbation, other adverse outcomes, and multimorbidity while also considering the patient's preference and goals. Non-modifiable risk factors such as history of past ICU admission should also be documented. For many patients in primary care, achieving good symptom control is a good guide to a reduced risk of exacerbation. When ICS were introduced into asthma management, large improvements were observed in symptom control and lung function, and exacerbation and asthma-related mortality also decreased. However, patients with few or intermittent symptoms may be still at risk of severe exacerbation. In addition, some patients continue to have exacerbations despite well-controlled symptoms, and for patients with ongoing symptoms, side effects may be an issue if ICS doses continue to be stepped up. Therefore, in control-based management, both domains of symptom control and future risks should be considered when choosing asthma treatment and reviewing the response. The asthma management cycle for personalized asthma care. Personalized asthma management involves a continuous cycle of assessment, adjustment, treatment, and review. Confirmation of diagnosis. First, assess confirmation diagnosis if necessary, symptom control and modifiable risk factor, comorbidities, inhaler technique and adherence, patient and parent or caregiver preferences and goals. Adjust treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, asthma medications including ICS, education and skill training, action plan. Review symptoms exacerbation, side effects, lung function, comorbidities, patient and parent or caregiver satisfaction. Assess the patient's symptom control and their risk factors for exacerbation, for decline in lung function, and for medication adverse effect, with particular attention to inhaler technique and adherence. Assess comorbidities and the patient's goals and preference, and confirm the diagnosis of asthma if not yet done. Adjust the patient management based on this assessment. This includes treatment of modifiable risk factor and comorbidities, relevant non-pharmacologic strategies, education and skills training, and adjustment of medication as required. For adult and adolescent, the preferred controller and delivered treatment across all steps is with combination ICS formoterol, as shown in GINA track 1. Review the patient in line with the goals of treatment, reassess factors affecting symptoms, risk of adverse outcomes, and patient satisfaction, arrange further investigation if needed, and readjust treatment if needed. Choosing between asthma treatment option. At each treatment step in asthma management, different medication options are available that, although not of identical efficacy, may be alternative for controlling asthma. Different considerations apply to recommendation or choices made for broad population compared with those for individual patients. Population level medication choices. Population level medication choices are often applied by bodies such as national formularies or managed care organization. Population level recommendation aim to represent the best option for most patients in the particular population. At each treatment step, preferred controller and delivery regimens are recommended that provide the best benefit to risk ratio for both symptom control and risk reduction. Choice of the preferred controller and or preferred reliever is based on evidence from efficacy studies, highly controlled studies in well-characterized population, and effectiveness studies from pragmatically controlled studies or studies in broader population or strong observational data, with a particular focus on symptom and exacerbation risk. Safety and relative costs are also considered in step 5. There are different population level recommendations depending on the inflammatory phenotype, type 2 or non-type 2. In the treatment figure for adults and adolescents, the options are shown in two tracks. Track 1 with as needed low dose ICS formoterol as the reliever is the preferred approach for most patients based on evidence of overall lower exacerbation risk and similar symptom control and a simpler regimen for stepping treatment up and down as needed compared with treatment in track 2 in which the reliever is short acting, beta-2 agonist, or in some cases combination ICS-HB. Patient level medication choices. Treatment choices for individual patient also take into account any patient characteristic or phenotype or any environmental exposure that may predict the risk of exacerbation or other adverse outcomes or a clinically important difference in their response compared with other patients, together with assessment of multimorbidity, the patient goals and preference, and practical issues such as cost, ability to use the medication, and adherence. For factors guiding the choice of inhaler, see section 5. The extent to which asthma treatment can be individualized according to patient characteristic or phenotypes depends on the health system. In the clinical context, the potential magnitude of difference in outcomes, cost, and available resources. Population level versus patient level decision about asthma treatment. Choosing between treatment options at a population level, the preferred medication at each step is the best treatment for this patient based on efficacy, effectiveness, and safety, mainly based on evidence about symptom and exacerbation from randomized controlled trial, pragmatic studies, and strong observational data, availability and cost at the population level. Choosing between controller options for individual patients. Use shared decision making with the patient or parent or caregiver to discuss the following preferred treatment as above based on evidence for symptom control and risk reduction. Patient characteristic or phenotype. Does the patient have any features that predict differences in their future risk or treatment response compared with other patients? Are there any modifiable risk factors or multimorbidity that may affect treatment outcomes? Patient views. What are the patient's goals, beliefs, and concerns about asthma and medication? Practical issues for the preferred controller and reliever. Which inhalers are available to the patient? Inhaler technique. Can the patient use the inhaler correctly after training? Adherence. How often is patient likely to take the medication? Cost to patient. Can the patient afford the medication? Which of the available inhalers has the lowest environmental impact? Yeah. Maybe that's all for the episode of 3. We will continue the next section in the next video. Thank you.